This is Dr. Atiemo, who was faculty here and defected to Henry Ford, and now is at ProMedica.
I'm flying all over the place.
Yes, he is. He's clinical associate professor at the University of Toledo, and it's my pleasure to introduce him. And he's had a lot of experience with residency applications as well.
Oh, yeah. Yes, we'll talk about that.
Yes.
Okay. All right, well, welcome, and it's such a pleasure to be here and see all the future faces of urology. I think this talk is titled My Story, which is really just to let you know that the road that you're on is a very common road, and sometimes you can feel alone, or you can feel like nobody's done this before, but certainly there's, camaraderie here, and all of you guys will probably make fantastic doctors already and fantastic urologists. And we're just trying to help navigate you guys through that road to become urologists. Okay, so I'll start with my story. And the title is Underrepresented in Medicine and Higher Education, Impact on Healthcare. And really, my story intersects a lot of the things that I've seen coming through medicine and becoming a urologist. And there's going to be some kind of themes in here that looks at who we are and why it's important to train the next generation of urologists and to have urology represented in all different facets in terms of diversity, different walks of life, ethnicity, things like that, because these diseases that we battle are not just unique to one population. And we're just mentioning that being a urologist, you have the opportunity to impact societies, healthcare, really the world. For several years, we meaning members of the University of Michigan and other faculty, have traveled overseas and worked in other countries, and global medicine is important as well. So there's a lot of things you can do as a urologist. It's just a first step in that process. Yes.
Is it?
Arrow, yeah.
Okay.
Okay, so we'll talk about my story. We'll talk about exploring healthcare disparities and then the link between healthcare disparities and being underrepresented in medicine, and then really have some ideas for the path for the future, which all of you guys are going to be part of creating the future. So my story really starts in Ghana, West Africa. So I'm Ghanaian, and I came over here in '74. So I'm not a young buck. Ghana's in West Africa, next to Togo, Benin, Nigeria, and that's me right there. There's my younger brother Andrew, my older sister Alice. So there's two more of us. You'll see them later, but we came over us here as the initial three, and then the other two were born here. And so, like, you come from that immigrant background. Many of you probably have that immigrant background, and just a privilege to have the opportunity to study and learn in this country and all the educational opportunities that are here. And, I mentioned education because really education and research is really the foundation for the future. The things that you learn, the people you're exposed to, the opportunities you have in your education really is what allows you to carry the step forward in terms of your success and then actually impacting success for society and the places that you'll work. So University of Maryland, that's my U of M, if you will. So I grew up in Maryland, and I was a wrestler. So I was a Division I athlete at the University of Maryland, and there's our mascot Testudo. So I always have to make a picture to take. Michigan doesn't have a mascot. So there's no opportunity. Yeah, exactly. So I have a mascot here, and family is very important. So I had the privilege of coming from a strong academic family and with a medical background. So all five of us, five of our family, are all in medicine. My dad was an OBGYN. My mom was a drill sergeant that made us, do all the work and everything like that. So she gets all the credit. That's why she's in a center. My sister is a internist. My brother's an interventional cardiologist. My other brother's an orthopedic surgeon, and my older sister's a nurse. And there's me with my U of M swag on for the time that I was here. And this is my family here. It's my daughter Charlie, who also wants to go to medicine. My son Joshua and my wife Sherry. We met at University of Maryland. So just things about my background. I've been well traveled and seen a lot of different institutions and universities. Starting at University of Maryland, then I went to University of Maryland Medical School. So I'm from the East Coast. Did my pediatric rotations at Johns Hopkins University, my fellowship at Cleveland Clinic, which got me to the Midwest in female pelvic medicine and reproductive surgery. Then I was staff here for 4 years at University of Michigan. I was program director at Henry Ford for 8 years. So I played this, getting you guys into residency thing, and now I'm at medical health at the University of Toledo and the residents there. Currently, I'm also a member of the American Board of Urology Exam Committee. So, early residents in here. Yes, okay, all right. So we're working on the in-service exam for next year. So we have to write questions and vet these questions and put together the in-service. We already did the board exam for, I think, July. You guys take the board exam. So it's just a good thing to be a part of, and you really learn how residents learn and make sure that we're testing you guys the right way so you can really be good urologists in the future. So that's been something I've been doing for the last 3 years. Okay, so let's talk about the impact of being underrepresented ethnicities in medicine. And these are studies that came out of the AAMC, and they really wanted to define what it means to be underrepresented in medicine. And those are the racial and ethnic populations that are underrepresented in the medical profession relative to the numbers in the general population. So if you look at medicine, a lot of people from different backgrounds are not in medicine or medical fields. And that does impact how these are treated or even access to care. So disparities are racial and ethnic differences in the quality of healthcare, and it's not due to access related factors, clinical needs, preferences, or the appropriateness of intervention. So the point is just having a provider from the same background as you will increase your opportunity to impact with the healthcare system and to get the care that you need. And we see this because there's a lot of disproportionate outcomes if you look at different racial and ethnic groups in medicine. There's several disease processes like that. So at my time at Henry Ford, I spent a lot of time teaching residents and teaching about the values of looking at people who are different and the importance of that and how to try to level the playing field so we all have an opportunity. So this is kind of something I borrowed from them. So it's a cartoon here, and you look at, in society, we have some people with privilege. So everybody's watching a baseball game, and individuals can stand really high on the platform here and see the entire game. You have a shorter person who can just with one little box see over the fence. You have somebody who's disadvantaged and cannot even see the game. Okay. So we have to recognize that there are differences in society. We all come from different backgrounds. We all have different inherent abilities, things like that. So equality means, well, we're going to level the playing field. Everybody gets a step, but that still doesn't, correct deficiencies that exist. And what we really want to get to is equity, where, there are in some programs opportunities to level the playing field, if you will, but that doesn't really fix it because that's more of where we are now, where you have different opportunities from different backgrounds to get into urology or things like that. We really want to have a system where there's no fence at all, so everybody with their opportunities can see the game. And so that's just like a constant reminder of there are differences in society. And if you pay attention and you look at the patients you take care of in medical school, you see who's coming into the hospital. If you work in the ER, you see kind of frequent flyers who come in there. You see that there's just different disadvantages that people have. We want to try to give everybody the great opportunity to be successful in life. Well, the US population is changing. If you look at it, this is a census data from 2012 to 2060, which isn't that far away, is that individuals in this country are changing from being primarily white. There's more ethnicities that are going to be represented in the country. And the two biggest areas here is going to be Hispanic, Latino in this country. And the next one are going to be people of mixed or two race descent. And so it is important to have the view that, the world that we live in is changing, and we need to be able to provide healthcare for a changing population. Okay. So the patients you see now may be very different from the patients you see when you get out of practice. Okay. So, why is this important? Well, population is changing rapidly. We want to improve the access to care for racial and ethnic minorities, a diverse workforce that mirrors patient population is key and an important step towards reducing healthcare disparities. A lot of times in residency, we're going to teach you guys cultural competency, which helps healthcare providers understand how to approach patients from different backgrounds by improving communication. But cultural competency is an important clinical competency and is really successful in practicing medicine in general. Okay, well, education. A lot of this comes back to education, and these are just some graphs that I pulled out from older studies, but these are patients who smoke, and we all know that smoking is bad. There's so many diseases like the smoking, but it turns out that if you only graduated from high school or no high school education, you were tended to be a smoker and you stayed smoking. This is from 1974 to 2015. However, if you had some type of college or higher education, the smoking rates in that population go way down. So education alone impacts healthcare. People smoke less if they have the knowledge and know that this is not good for me. And we know that this impacts life expectancy as well. So these were tables, where you get like insurance and things like that. They calculate in your life insurance, like how long you're expected to live. And there are definitely differences if you're Hispanic, Latino, black or white. And we can see here, black males in this population really have the lowest life expectancy of only 71.8 years. We're getting better. I think these are older numbers, we're closer to 76, but still there is a difference in life expectancy of individuals based on their ethnic racial backgrounds. And this was really borne out in the COVID-19 pandemic, where you looked at who were the individuals who were dying from COVID-19, who were the ones that were being hospitalized, who were the ones that were, had to be in the ICUs. And you guys must have missed it, right? So it's 2025 now. So were you guys first year medical students, or was just after? It was just after. So a lot of these things were happening the last year's class or the year before after the experience. This is part of medical student. But here you can see the numbers that Latino, Hispanic, non-Hispanic, Alaskan, Native American Indian, and non-Hispanic Black were the highest ones that were hospitalized, ICU admissions, or died from COVID-19. So there is a difference in how disease impacts different racial and ethnic groups. And we already know about the cancer disparities that exist. So African American women have a lower incidence of breast cancer, but they have a higher mortality rate. Triple negative breast cancer is particularly common among African American women. And this type of cancer is associated with decreased overall survival. African American women have breast cancer patients have more cancer recurrence and progression. There's racial disparities in colorectal cancer, and we already know about prostate cancer. Prostate cancer mortality is about 2.4 times higher amongst African Americans. So if you in your studies, you'll see that different groups are impacted differently by diseases. So how can we impact this? How do we make a difference? Well, so let's look at where we have as minorities or underrepresented individuals in medicine. So if you look at education, which is really the foundation for fixing all of this, there's a huge difference in Black males, particularly if I just focus on that group, getting a higher degree. Many of them will get some college education, but very few numbers compared to white males will actually get a bachelor's degree or a graduate degree. Maybe they get a couple of years of schooling, a couple of years of after a high school GED. So there's a difference here in terms of education and being able to pursue higher education. And I'm sorry that didn't come out right, but the landscape for minorities in medicine, the lowest represented group are African Americans in medicine right now. And that's something that we've been aware of for many years and have been trying to impact and change. And this is not just urology. I'll show you some urology data later. But if you look at who's applying to medical schools, right? Well, you have a lot of of white males that apply. You have a lot of Asians that apply, and then you have all these other smaller groups. And so we really want to have opportunities for everybody to get into medicine and really push higher education and in the medical field, it's everybody. So how this came out in 2015, which is altering the course of Black males in medicine, which is like the lowest group. And this study looks from 1978 to 2014, and the numbers have not budged. If you look here, this is the red line represents African American males, and that line is completely flat in terms of the numbers who go into medicine, graduate medicine, and are clinical physicians. And so you have a nice increase in Asian population. The Latino population is very flat as well. And there's a slight reduce in Caucasian and white population. So as we look forward, we can see that there's these gaps there. There could be opportunity gaps. There may be differences in the educational process, but these disparities definitely exist. Women are doing fantastic. So many women are pursuing medicine. Actually, University of Michigan was one of the first medical schools to allow women actually in their medical school class, 18 something. So that's one of the big kudos to University of Michigan. But women have actually increased the number in terms of coming into medical schools. And so it's about level now, about 50-50 women in medicine. We still have a ways to go with urology. I don't have a slide on that. I think we're up to maybe 12% of urologists are women now. A few years ago, it was 9%. So as we keep pushing further, we're getting more. Yes.
The data for it's almost 50.
It's 50-50. Yeah.
Like the last 8 years,
Yeah. And I think there's been a big push. We have, you're talking about medical school, or are you talking about
urology.
Oh, urology, yes. 50-50. So we have a lot of groups like SWU and opportunities for women to get exposed to urology earlier and to have more women in urology. So about 12% is where we are now. As they matriculate, those numbers will continue to go up. So there's efforts being made, but it's a process. If you look at educators in medicine, if you look at who are your professors in medical school, who are the people who are teaching you? And if you look here, there are far fewer numbers of minorities who are actually teaching in the medical school at the PhD level and things like that. So you can see that there's some differences there already in terms of who your lecturers are. And then women as faculty, although we're getting more women in there, the only group that actually has more women faculty than males is African Americans. So there's more women faculty in that group. But in all the other ethnicities and racial groups, it's always more men than women in pursuing academia. So certainly there's opportunities everywhere if you want to pursue academics and you're a woman, things like that. But these are just snapshots of time of where we are, just so you know how things are going. So we did some studies looking at diversity in urology, and we wrote this article in Urology Clinics in North America, looking at diversity in urology alone. And what we found is that the numbers are increasing, which is a good thing. Since 2020, there's an increase in underrepresented medicine applying to urology residencies. The match rate is statistically unchanged, however, in the last 5 years. And minorities still match at a slightly lower rate than white applicants. The match rate of Black and Latino applicants are actually inversely proportional. So one year you have more African American match, and the other year you have more Latinos match. It all depends on who's applying in those particular years. Progress is slow, but a lot of the initiatives that we've been working on, it's just going to take time. Like women in urology is a big field that to get more minorities in there. It probably goes back to things like Title IX and those opportunities to get more women in college, and so that has pushed forward. That's 50 years now, since the 1970s. So, these efforts are going to take time as well. I looked at my own area, which is female pelvic medicine and reconstructive surgery, and we did another study here that looked like it's still smaller proportions of ethnicities in FPMRS, but you see that the numbers are increasing, and here the blue line is, looking at all the fellowships, female pelvic medicine, oncology, pediatrics, and the urology stone disease. And there are more URM students in FPMRS for whatever reason, I don't know why, but at least that's a specialty that, has attracted more, and so on and so forth. Oncology has been relatively flat, if you will. Yes.
With this, did you look at current faculty at places that are at PMRS and identifies underrepresented? Because I know I can think of a few off the top of my head that
Yes.
are underrepresented. They're faculty and program directors
In terms of,
and underrepresented men.
yes, and so and then FPMRS. So yeah, so that's where this trend shows that FPMRS is probably the highest area that they're doing fellowships in, as opposed to oncology and other fields. So this data ended in 2019, so we still have another 5 years of data to collect, to look at, to see if that has changed, which is all. But the trends are happening. It's just a very slow thing. So why is it important to improve access for healthcare? Well, as I mentioned, this is a slide I showed before. The population in the United States is changing, and there is still going to be a shortage of providers. And in all of my travels, I've seen that patients have to drive further and further to get to a specialist, and urology is a specialty. And so there is going to be between 20,000 to 70,000 shortage of physicians in non-primary care specialties, about 17 to 48,000 in primary care specialties. We try to fill a lot of that gap with mid-level providers, if you will, particularly in primary care. And we're trying to do some in urology. We have a lot of PAs in urology now. But in terms of surgical specialties, people who can operate and really fix things, the deficit is still going to be huge, 15 to 30,000 physicians short. What does that mean? Patients have a longer time to get to the doctor, they have a longer wait period. And if you're already from a disadvantaged community, then that's going to set you back even further. What does that mean? Well, maybe that kidney tumor or that prostate cancer, but these, kidney stones don't get treated in a timely fashion, and it takes longer. And those all turn into poor outcomes, if you will. Just that delay. So, there's a great opportunity we need more doctors, more doctors from different backgrounds to really do this. So where do we begin? How do we make the change? I've kind of laid everything out for there. And I think it really starts by, we have to increase our capture of people from different backgrounds and ethnicities in higher education. So I really think this program, we got to duplicate it for high school, right? So we've got to get those kids who are in high school interested in higher education and say, listen, let's not just think about college. Let's think about what do you want to do after college. There are some barriers there that we have to, financial barriers and things like that, but we want to get people thinking about higher education earlier. That's number one. So we want to expose people and encourage minorities into a medical profession then. Say, hey, listen, have you thought about medicine? This may be a good field for you. And then we know that if we have more individuals there, it will impact healthcare and the community. These are just some studies that said that, if you look at pipeline efforts, we really even start at the elementary school age and having people think that, hey, listen, I can be a doctor too. And that really impacts a lot of people. There's opportunities always to serve your community. Maybe you guys have already done that in med school, where you go to different schools and talk to them. And it's important that they see you. People are always watching. You don't really realize that, but people are always watching you. And so if people see that you've gone so far, you kind of pay it forward, and they'll follow your footsteps and achieve the same great things you guys have all achieved. So we have to do a lot of encouraging. So some people have personal perceptions that I can't make it. I'm not good enough. I don't come from the right background. I don't come from the right medical school. I don't come from the right undergraduate school. All of those are perceptions, and they're not true. And there's great doctors from all different walks of life. Mentorship is important. Programs like this, mentoring opportunities, speaking with somebody who has a similar or even divergent background, but you just need to talk these things out. everybody has unconscious biases, you know, like when you see an individual, you already think, oh, they're gonna give me this answer, and you have to realize that those exist and work through those. There are significant financial barriers, even coming to a program like this. And we know that financial barriers prevent people from pursuing higher education, which is something that's important. I was lucky to have some scholarship opportunities in undergraduate medical school that helped foot my bill. But I know that I think it's an average 300 to 300,000 for medical school that you're having now. So that's a lot. I mean, that's a whole mortgage, you know, to start your life out, you know, on a mortgage payment. So financial barriers are important. And then we need to continue to reinvest in the process. So just because you've made it, and all of you guys have made it, you know, your fourth year, you're about to graduate. But just remember that there's other individuals who are coming up behind you that are looking for guidance. You guys could be great mentors for them as well. And all of that says it really cultivates resilience because it's a process and every day is a step forward. And there are many times in my path where I felt like maybe the moment was too big, or you know, everybody has this little bit of imposter syndrome that they carry inside of them. You know, do I belong here? Can I do this? And you have to have resilience and kind of think your way through that and say, listen, for this situation, I'm the best person here. I'm the best trained, and you know, you can meet the patient's needs, you can meet society's needs, and even in academic medicine, you can really thrive there as well. Removing barriers. So one of the things that we've done over the last few years in terms of medical school applications, and we've kind of transitioned this into residency application as well, is to have a more holistic review of the application process, which we'll talk about applying and things like that. But you know, it used to be that everything was just cut and dry. You had to have this score. Anything below the score, you weren't good. If you're above, you had a shot. And with a holistic application process, the scores are just one metric in terms of everything else. Because you know, we're not just, we don't want doctors just to be test takers, right? You have to be able to talk to patients, you have to be able to have healing hands and things like that. So a holistic process is how we look at applicants now. And most of the medical schools, if you think of it, have gone and pass fail at least for the first 2 years. Is that right? Because I remember reviewing applications and I was like, they changed the step one score. So it's all pass fail. I haven't heard about step two scores changing yet. No. So step one is all pass fail. And then mostly for the first 2 years, I think it's pass fail. Some schools still keep grades, but several medical schools in the first 2 years just make it all pass fail. So I think it's like we're really trying to teach you so you're not just aiming for a number, you're actually aiming to learn medicine and aiming to you know, have these other skills that we can develop besides test taking. That being said, I do write test questions for the board, so very important for test taking.
I know who to blame now.
Yeah, exactly. So with this lecture, I want to go ahead and just acknowledge some people in my life that have helped me along the way. And I think all of you guys will have people look back that helped you along the way, where when you didn't think you could take that next step, they pushed you forward. Sometimes they had to kick you. But at least you kept moving, and that allowed you to be successful to where you are now. So every person on this list has a story, and I'll tell you a little bit about a story. So Principal Guthrie was my third grade principal, and I went to a small Christian school in Maryland. And this is back in the days where they could paddle you, they could beat you. And so I quickly set the record for being paddled at school because I was fidgety and I couldn't sit still. And so I was like, well, go see the principal. And he had two paddles. He had a yellow paddle, which was like lighter, and a black paddle, which was heavier. He got 5 whacks. Okay. They've taken corporal punishment out of schools now, but it worked for me. It worked for me. So somehow that steered me a little bit closer. Mr. Alexander, this is now I'm in 4th grade, and I was really struggling with school. I just could not pay attention in class. And he really had a discussion with my parents and said, well, I don't know what's wrong with your son. And I think we have to spend, this is when they had something called special education. We called it the wing. So all of the difficult kids got put into a different, they sequestered them away from the smart kids. And that's actually bad because a lot of schools now, they want to integrate the kids and just give them more programs to help them with their learning disabilities and not because they really don't learn when they get sequestered out. So, but he came to my parents and said, I think he has a learning difficulty and we need to put him with these other kids. And my mom said, no, he's just, his mind just goes all over the place. So then she transferred me to a private school so they wouldn't do that and they would spend more time with me in class. Well, when I went to the private school, I was still not paying attention. And the funny thing is I was in the back of the classroom and I had my eyes tested. I couldn't see the board. So then I would just, daydream. So then they figured that out, moved me to the front of the class and got me glasses and everything changed, right? So little things like that. Mr. Johnson, he was the world history teacher in sixth grade, and he really inspired me in terms of history and learning and things like that. And it's like a really big impact. Like everybody has like a teacher in their life that, you just remember because they really impacted you. And when I got to college, my college counselor was turning me in hits. And I was like, yeah, I think I want to go into medicine. And I think I want to also be a student athlete. And she was like, no, you cannot be a student athlete and pursue academics. And I said, I think I can. And so my whole goal was to prove her wrong. And so then, I became captain or co-captain of the wrestling team and, went to the NCAA tournament, things like that, and all while keeping my workload. So I proved her wrong. But during that step in college, I had my organic chemistry teacher. Organic chemistry is like a terrible class, right? Everybody was struggling with, yeah, I had to see the heads, right? So Dr. Mizuki came and she was fantastic. And I said, Doctor, I took a test one day because I, wrestling, you have to lose weight. So I had lost 10 pounds, had not eaten for 2 days to make weight to go to NC State for a wrestling tournament. And I bombed my organic chemistry test. And I came to her and I showed her the test and I said, I knew every one of these answers, but I was hypoglycemic. And I just answered everything wrong. So she had a lot of mercy on me and she helped me, I guess, study better and eat before the test. And I ended up doing well in the class. And then Dr. Higgins was my physiology professor who knew the admissions counselor at University of Maryland. And he wrote me a great letter of recommendation and really pushed me forward. When I got into medical school, I thought I was going to do ENT, ear, nose, and throat. And I was like, yeah. And then all of a sudden, I just did not like snot. I just couldn't deal with it. I couldn't deal with the saliva and everything like that. So then a buddy of mine gave me the Urology Secrets book and said, read this book, do urology for 2 weeks. So I did it. And my chair at the time was Stephen Jacobs. He passed away. And Stephen Jacobs said, you're going to be a urologist. And I said, what do you mean? And he had so much confidence in me that really lit the fire under me. And I pursued urology. And sometimes you have people in your life that'll just push you and say, you can be a urologist. And that meant a lot to me. So in residency, Toby Chai, who graduated from here, so everything circles back to Michigan, if you haven't figured that out. So Toby Chai was here. He did his residency here, and he was my research mentor. And he did a lot of neurogenic bladder reconstructive, and I worked in his lab for a year studying bladders, rat bladders, and that really lit the fire in me to pursue female medicine. Female pelvic medicine, reconstructive surgery. So along the way, all these individuals have impacted me to push me where I'm at and to help me to kind of give back to the same way in the same community. And so I really appreciate all these people in my life. So with that, I'll end. I'll take questions, but I think all of you guys are on a journey. This is just my story of my journey, but the things that you do here on out impact not just yourself, the community, people that look like you, people that don't look like you, and can really impact, the future of the country and the future of medicine and in your life. Thank you.